Yeah, that looks.
And then if I go forward, do you see the picture?
Yeah. Mm-hmm.
Okay. All right. So 63-year-old lady. So her vision started getting worse in 1988 when she was 27. She felt like when she was sitting at her desk, her vision was distorted. She didn't have any laser. She was in Dallas at the time and she was sent to Hopkins. They thought she might have histoplasmosis, but they didn't do anything to confirm it. One thing for OCAPs, if presumed ocular histoplasmosis, they have like 90-something% positive on skin testing for that. That's OCAPs relevant. Otherwise, medical history, she's got history of thyroid disease, GERD, history C-section. These are some of her meds. So her right eye, the vision is 2100, and the left eye, she's 20/25, and IOP was normal. So tell me what you see on this.
So we have a fundus photo of the right eye. Vitreous looks clear. Disc looks flat. There's some peripapillary atrophy. Vessels look pretty normal. And then in the fovea, looks like there's a large hole with some pigment in the inferior portion. You can see the choroidal capillaries under it.
Not really the capillaris. What are those big things?
Oh,
those,
yeah, what are those?
The choroidal vessels.
Yeah.
Choroidal vessels, okay.
Yeah, capillaris is shot.
Anything on this?
So
white spots and artifact.
Yeah, this here is artifact.
Sorry about that.
Okay. Media looks clear. Again, some peripapillary atrophy around the disc. Vessels look okay. And then in the fovea, it looks like we have some light-colored punctate lesions, maybe some drusen. And then looks like a loss of the normal foveal reflex.
All right.
And so here's some IR. It looks like a window defect around in the whole area region. And then again, maybe we can see a few more of those bright punctate lesions in the macula and in the fovea. And then, so autofluorescence. So there's where the region with the hole, there's, I guess, a window defect or just a lack of any autofluorescence. And then surrounding, there's a ring of hyper autofluorescence.
But yeah, you can see just hypo and hyper. That's good.
Hypo and hyper. Okay, and then in the left eye, we have that outer ring of some hyper autofluorescence, and then more in the fovea, there's maybe some hypo, but that might be normal.
This is pretty normal. Your autofluorescence can be variable. It's pretty normal.
So we have an OCT of the fovea, and
that's the right eye.
It's the right eye. Along the foveal contour, we have, it looks like loss of the outer retinal layers, and atrophy of the RPE.
Yeah.
And then this presumably is the left eye. Looks like there's a nice PVD. The layers look fairly well intact throughout. Maybe a little bit of a concavity just next to the fovea in the RPE.
So this is kind of like a couple of scans to get a better idea of that concavity that you pointed out, as we can kind of go back and forth through it, kind of get a good idea of that.
This, yeah, paracentral.
Yeah, so basically this is, pointed out some of the stuff you had mentioned. The left eye, I did think that whenever I was going on over this case on my own, I did think that some of the stuff you said, where there's like some subtle findings in that I thought were there in the left. Dr. Cohen said they're pretty much nothing that you would really see on normal exam, but definitely at the on the OCT, there's that focal concavity, pretty much exactly as you described it, that RPE choriocapillaris line in the choroid on the OCT. So although the right eye is, her worst vision eye, the finding on that one is kind of obvious. So, I just kind of mentioned some stuff for differential on the right. The left eye has that, interesting finding.
If anybody knows the name, they go back. What that's called.
Yeah. So, has anyone seen something like this before?
The title of the presentation
Yeah.
is Choroidal Excavation.
I had never seen this before, so I didn't want to waste a bunch of time like, oh, what could it be? Because I had never heard of it. So I'm just jumping into it. It's choroidal excavation. So I mean, obviously, like the right eye findings were pretty obvious. So what I'm here is like the less common thing is the left eye finding, which is choroidal excavation. So it's relatively newly recognized. It's usually incidentally found, and there's usually either no decrease in vision or very mild decrease in vision in the affected eye. Pretty much since OCT has come out is, when it's been noticed. There's some really subtle findings that you might see on like indirect ophthalmoscopy or if you're looking with the 90 diopter or the slit lamp, but it's really the OCT that differentiates this finding, which is, like I said, it's focal concavity of the choroid. There's no local scleral changes. And just a little bit more about it. It's usually unilateral. And then the majority when I was looking through the literature, the majority were thought to be congenital, but the etiology is kind of unknown. They're usually stable over time, but they may end up developing either choroidal neovascularization or a serous retinal detachment. So some risk factors for this choroidal excavation. It's associated with myopia, as well as pachychoroid. So, you can sometimes see it in other things that can be associated with pachychoroid, like CSCR or polychoroidal vasculopathy. More common in women than men, and more common in the Asian populations. And there might be a correlation between this finding and then wet AMD or the Bestrophin diseases. And then one thing I was reading was saying maybe EBV or MUDES. So there's a bunch of different classification systems. Some are like if there's a separation between the photoreceptor outer segments and the RPE versus like no separation versus a separation. Some are based on the shape, so it's either cone shape or bowl shape or like mixed. And some are if it's found in the fovea or extrafoveal. And apparently the foveal one is more common, the cone shape is more common. And then I don't think that the conforming one made much of a difference. So then this is really an OCT finding. There's that focal concavity, like I mentioned. FA and ICG may be utilized because, like I said, it can end up developing CNV. So FA ICG may be helpful for following that, and OCTA might also be useful. Just some other things on the differential. Whenever you're looking just at the exam itself, it can kind of mimic some of these, but like the OCT is really the diagnostic gold standard and really won't be confused for other things. Just observe them, but then if they develop a secondary CNV, like an anti-VEGF, and then what I was reading was saying that some people were using PDR or focal laser. I guess the focal laser may be more if it's like extrafoveal, but patients are usually just stable with observation. So that's it. A short, quick one.
It's kind of a weird one. It's just one more thing to know. So very good. Yeah, that's a tough one.
So the other eye though, it is posed.
I don't know what the other eye was. I was thinking about that because in 1988 there were certain diseases that weren't described yet.
Well,
So
was that our excavation, or the excavation was the other eye?
the excavation was a good eye.
The excavation was the good.
It's right here. And you're true. It might be that little pigment spot there, but the I don't think I would share anymore. But the yeah, that scar, that's a tough one. I mean, it looks kind of like a toxin scar. It might have been histo. I mean, the guys at Hopkins
so
are pretty smart.
in the differential for that, I said like histotoxo,
Yeah.
like
Yeah, there's a little the red overlying. It's a little bit intact for toxo. That might have been why they called it.
It's just so central, so macular.
Right.
Did the patient get laser?
No, they said no laser. I asked her, because it looks a lot like a laser scar, doesn't it?
Maybe they.
She's
forgot.
pretty sure she didn't get laser, but yeah, you might be
Because
right.
choroidal excavations, I think, Steve, you can correct me if I'm wrong. I think they're associated with central serous. So I wonder if she had fluid in the right eye and they lasered it and then she got the scar.
I don't think so. She had sudden severe vision loss at age 27 and went to Hopkins. I can't imagine they would have.
Well, that could have been
Literally,
just
Foster said she did not get laser.
Yeah, she said, I asked her, and she's a pretty good historian. She said no laser. But yeah, and I would hope they wouldn't obliterate her macula like that, or even, have a spreading scar. But it does look a lot like a laser scar. Although